If April showers bring May flowers, what do May flowers bring? Pilgrims. Welcome to another Persiflager's Puscast. Review the infectious disease literature with commentary covering the last 2 weeks of April 2012. This is brought to you by Pusware LLC, publisher of the Infectious Disease Compendium, a Persiflager's Guide, your Uber hyperlinked electronic guide to infectious diseases at moremark.squarespace.com. The purpose of this podcast, as always, is to review the infectious disease literature over the last several weeks and then give commentary and otherwise declaim and pontificate on those articles that are of interest to me and perhaps to you. It's not meant to be comprehensive. It's just what I think is cool. This is available on iTunes, where you probably got it. And remember the most important thing. Go on iTunes and write me glowing reviews. Otherwise, you can find my growing multimedia empire with links to books, blogs, and iPhone apps all over at moremark.squarespace.com. But for now, let's move on to the literature. There was a single case of mad cow disease found in a dairy cow in California this month. Mad cow is not spread by drinking milk, so it should be safe. And they don't think that mad cow is a threat to humans under this circumstance, which is probably true since both Gingrich and Santorum are no longer running for president. No, wait, that would be mad bull disease. And since I want to keep my family rating on iTunes, we'll leave it at bull. There are two mystery diseases in the world right now. In Africa, there's nodding disease, where kids get lethargy and they nod their head and then die of seizures. Pretty awful. And now there's a mystery disease as well in Vietnam that's killed 19 and affected about 200. It's waxed and waned since 2011, and it manifests as a combination of limb stiffness and palmar plantar keratoderma. Now that is weird. I just mention it as we're heading on to summertime, and if you're going to be vacationing in Vietnam, a place I would dearly love to visit for the food, come home with a case for me so I can see what it looks like. I have Monty Python on the brain, and whenever I hear the word moose, I think of the end of Holy Grail and the importance of moose bites. Moose bites can be pretty nasty, you know. There's also a different kind of moose, the meta-analysis, observation studies, and epidemiology. So what does the moose study show about the risk of transmitting hepatitis C from tattooing and piercing? Well, there's no big surprise here that if you get your tat from your friend or in prison, your risk for hepatitis C goes up. What a surprise. But it's good to know that if you get your tattoo in a tattoo parlor, you're unlikely to get hepatitis C that way. There are worse things, however, than hepatitis C. And if you go to failblog.org, they have a subsection on tattoos that will give you the willies and make sure you're never drunk when you go to a tattoo parlor. Now we're going to talk about blips, not Space Ghost's monkey. Boy, I do need some medications with these flight of ideas today. But HIV blips. When you have someone on fairly active antiretroviral therapy and they're suppressed, occasionally their viral load will pop up a little bit, and you kind of worry. How much should I worry about this little blip in the HIV in a patient who is suppressed? This study did all sorts of fancy schmancy statistical analyses on patients with blips and found that if it was between 50 and 499, it was not associated with virologic rebound. Whereas if your blip was between 500 and 999, you were more likely to go into a virologic rebound. So if someone's blipping along in the low 50s or 60s, it's not as worrisome as if they get up into the 600s, 700s. They also found that the blips were more common in patients on boosted protease inhibitor. They hypothesized this may be because patients on those regimens tend to have more advanced disease or have more trouble with adherence with their compliance. Anybody besides me watch Space Ghost Coast to Coast back in the day? That was a funny show. Squirrel. There was a report looking at LCM in southern Spain. They had 2 cases of LCM, lymphocytic choriomeningitis virus, and it accounted for 3% of the pathogens found as a cause of meningoencephalitis in Spain. I only mention it as this is one of several studies to suggest that it is worthwhile to check serology for LCM in patients presenting with aseptic meningitis, that mice frequently carry this, and it's not just hamsters. And I routinely don't check for LCM, and I probably routinely should. There are lots of rodents out there that carry it, and people inadvertently come into contact with rodents. I spend a fair amount of time fretting about vaccines, vaccine wackaloons who are against vaccines, and across the board, vaccine adherence has been declining. Some places in California, schools can have like 70-80% of their kids not vaccinated with the routine vaccinations of childhood. There's huge problems in Europe right now with thousands of cases of measles. So if you're planning on going to Europe for a vacation instead of Vietnam to catch a mystery disease, I might get to see my first case of measles. There have been 222 cases of measles in the United States in 2011, attributed with 17 outbreaks, and that's 4 times the number of cases seen in the past decade. So thank you, Jenny McCarthy. Thank you, Andrew Wakefield, for helping make our children sicker. I also mention it because I don't know about you, but I don't think about measles when I see fevers and a rash. But given the resurgence of the disease and the potential for spread by way of airplanes, think about measles the next time you see fevers and a rash and see if they have the classic triad of cough, conjunctivitis, and coryza. A report from Pediatric Infectious Diseases, which is kind of redundant as aren't all diseases in kids infectious. Anyway, they looked at the resistance of Mycoplasma pneumoniae to macrolides in the central United States and found that 8.2% of Mycoplasma pneumoniae are resistant to macrolides. Further information that we're slowly sliding into the post-antibiotic era. The same thing is happening, at least in Germany, with Mycoplasma hominis and ureaplasms, where they looked at susceptibilities over a 20-year period. They found that doxycycline was the most reliable agent against both ureaplasms and Mycoplasma hominis. Turns out, though, that Mycoplasma hominis about 10% of the time is resistant to tetracyclines. Ureaplasms are resistant about 3% of the time. Ofloxacin was susceptible. And clarithromycin and one I've never heard of, jossamycin, were potent against ureaplasms, but erythro and clinda were unreliable against ureaplasms, but potent against M. hominis. So the take-home is that if the patient doesn't respond to one, it could be because of resistance. It could be of co-infection with another organism that is resistant. And if you have a co-infection, you may need to give combination therapy if they don't respond to single drug therapy in treating NGU. Proton pump inhibitors are a risk for developing C. difficile. C. difficile is ubiquitous in the food that we eat, and if you get the combination of an acid suppressant plus an antibiotic, you A, allow the C. difficile through, it's not killed by the acid, and B, the antibiotics give it a place to multiply. It is, it turns out, also a risk for the development of recurrent C. difficile. So patients who have recurrent C. diff, the only thing they found in common in this study was the use of PPIs. It made the rates 47% versus 5%, which is pretty impressive. So if you have someone with C. difficile, step one, get them off their acid suppressants. There is a fish called the olive flounder. Its name is Paralichthus, I guess. Olivaceus. Paralichthys. It is evidently a popular dietary food in Japan where they eat it raw. And I do love sushi. They had an outbreak of over 1,300 cases of diarrhea that was associated with eating the olive flounder. They subsequently went looking and they found a new species, an Myxosporian species, that they've named Kudoa septempunctata, which sounds like a song from The Lion King. Kudoa septempunctata. Watch me try and mangle yet another parasite. So that's Kudoa septempunctata, is a cause of watery diarrhea from eating sushi from the olive flounder. And Nichols says that shows up in the boards in the next couple of years. And you heard it here first. It's amazing what you can eat. So there's this raw tuna product called back meat. What back meat is the meat scraped off of the bones of tuna fish. And it's done in a processing plant in India and frozen and then sent out to be put into dishes like sushi, sashimi, ceviche, and spicy tuna. They had an outbreak in multiple states due to salmonella, where this back meat from tuna scraped from raw tuna was contaminated with salmonella in India and sent around the world. I think I'll cook my tuna back meat and my olive flounder in the future. It's referred to as the Naka-ochi scrape. Give me that Naka-ochi scrape. It's always a mistake to do widespread treatment without susceptibility testing. I vaguely remember a study years ago that demonstrated that if a patient had been on clarithromycin in the last year, their H. pylori was likely to be resistant to clarithromycin. This study looked at the usefulness of doing cultures in susceptibility of H. pylori and then giving them the treatment versus the standard, let's see what we can throw at the wall and see if it sticks technique. They found that the success rate in those who had cultures and susceptibilities was 89% versus only half of those who had a breath test and then got empiric therapy. It was considered cost-effective to do the endoscopy in cultures, having cost $571, actually 571 euros in the group that got cultures versus 666 euros in those who had empiric therapy because of the higher failure rates. 666. I think there's a hint there that you should not be using empiric treatment. Now, of course, it's difficult to get cultures on everybody, and it's not part of the standard lab. But I think one of the things you're going to be doing by treating people empirically without cultures and susceptibilities is driving Helicobacter resistance, which is already happening inadvertently by treating other infections with drugs that should be beneficial against Helicobacter. The motto is always use it and lose it. You probably know that hypothermia increases the risk in surgical patients. As part of the skip procedures, we try and keep patients warm during the perioperative period. The study out of France looked at hypothermia in people in the ICU and found that the colder they were, the more hypothermia they were, the more likely they were to develop a high CU acquired infection. So hypothermia is bad in surgical patients. Hypothermia is bad in medical patients. It's good to keep people euthermic. I'm back from my walk. Did you miss me? You'd be surprised at how draining doing these podcasts are. It actually takes a lot of work to not only read papers and talk about papers, but I get one shot to get it right, so I have to actually pay attention to what I'm saying, which surprisingly you don't need to do much in real life because you can always repeat yourself. But you don't get to do that in this Puscast. So some Staph aureus stuff. first looked at the nosocomial transmission of MRSA in Danish hospitals. And they found a total of 117 index cases of MRSA. And then they looked at post-contact screening of patients and healthcare workers, 1,108 thereof, and found 52 secondary people got infected from the index case of MRSA. Interestingly, nosocomial rates of MRSA were lower if it was a community-acquired MRSA than that if it was a hospital-acquired MRSA. 9.3 times lower, in fact. So while Staph aureus is spread in the hospital from patient to doctor and nurse to patient, it's more likely to occur if it is a hospital-acquired MRSA. It might be because people with hospital-acquired disease have more fastidious infection control. I don't know. Shakespeare once had a character say, "I am a woman, I cannot think a thought ere I must speak it." I think that's kind of sexist, but I always kind of like the quote. And sometimes when it comes to infectious diseases, some people have the idea, I cannot think of a pathogen ere I must treat it. This happened this week where a patient had to be treated for MRSA because they thought of MRSA. How often does MRSA cause community-acquired pneumonia? Looks like that answer is pretty much close to zip in this article, accounting for 2.4%, or 14 of 627 patients who had MRSA pneumonia. The patients who had MRSA pneumonia were those who had a history of MRSA, people who had nursing home contact, people who had contact with someone with skin infections, and intubation. So MRSA, at least, is an unusual cause of community-acquired pneumonia. Though not mentioned in this study, it's also important to remember that MRSA pneumonia is a definite complication of influenza pneumonia. And lastly, what is the source of coagulase-positive staphylococci? This study looked at the incidence in dogs and their owners and found that occasionally both the dog and the human had the same Staph aureus and the same Staph pseudointermedius. And so it is not unsurprising, but Staph aureus and Staph epi species can be spread back and forth from people to dogs and back. It's why whenever I have an outbreak of MRSA in a patient, I always suggest they autoclave their pets as part of the decontamination procedure. You'd be surprised how much they whine when I tell them to do that. I mean, I love the quote in the paper. Substantial proportions of participating dog owners not only shared their house, 88.9%, with their pets, but also their sofa, 68%, or their beds, 40%. Many dogs had obviously gained a status nearly equal to that of a human family member, i.e. the animals were given privileges formerly exclusively meant for humans, which are behavioral aspects typical of anthropomorphism. You get a pacer infection, you got to yank the pacer. And there's a nice review of this in JAMA this month, where they looked at the International Collaboration of Endocarditis Prospective Cohort Study, which spells ice picks. Better, I suppose, than moose. But they looked at 177 device-related cases of endocarditis out of their 2,700 patient cohort, which is a lot of endocarditis. And they found that if you left the pacer in, a third died. If you didn't, about 20% died in the next year. If they also had a coexisting valve infections, then the patient had a higher mortality rate as well. So and there have been other studies I have talked about that showed the sooner you take them out, the better the outcomes. Of course, some patients don't do well when you take out their pacemaker. They're dependent on it. And the cardiologists always fret about the mechanical issues like rupture of the heart when they pull these, but fortunately it has yet to happen in any of my institutions. It can be problematic as to whether or not these are infected if you happen to have $5,000 or $6,000 lying around. perhaps a diagnostic test of choice to help work up the patient, besides a TEE, is a PET scan. A recent study suggested if a PET scan glows in and around the pacer, that you have a reasonable probability that it's infected and can justify taking it out, which they say has about a 2% complication rate and a 0.8% mortality rate. So it's not a trivial problem by any means, but certainly the sooner you can diagnose it appropriately and get it out, the better. So the $5 or $6 spent on the PET scan may well be worth it. What do you do with a catheter that is positive for Candida, but the blood cultures are negative? There's some data to suggest that if it's Staph aureus, they have a chance of invasive staph infections. But Candida is the other bug that loves to go places once it reaches the bloodstream. This study looked at all the colonized catheters in patients who did not have a documented candidemia. It was a bad thing. 40% of the patient died, but not due to Candida. And 22 of the patients in the series received antifungal therapy. Of all the patients in the study, only one had a metastatic complication, a chorioretinitis, which accounted for about 2.5% of the patients. There was no subsequent candidemia in these patients. So it would appear that the risk of candidemia in patients with intravascular catheters is low, but ... Candidemia has always been notoriously harder to document than bacteremia. Nothing escapes the intravascular component faster than Candida albicans. It would be interesting to do a similar study, but do beta-glucan levels. In addition, there's another recent study in the Journal of Clinical Microbiology showed that patients who had beta-glucan levels with invasive Candida did better if their levels fell and did worser. I always like the word worser if the levels did not. I keep wondering about the utility of beta-glucan to detect occult candidemia, and perhaps it would be of interest to do it in patients with line-related colonization. There's a study for you. You're kind of bored, aren't you? And it does get to the point that removing the CVC is important in patients with suspected candidemia. This study was published in Clinical Infectious Diseases, and they call it a major article. They call everything a major article. I'd like to see them publish something that they say, this is a trivial piece of crap article. But this article looked at treatment strategy on outcomes in patients with candidemia. And they found that there were two factors that were associated with improved survival and greater clinical success. The first was using an echinocandidin. Certainly up front, everybody in whom you have suspected or documented Candida should get an echinocandidin, such as caspofungin, anidulofungin, micafungin. But it's interesting that this reinforces the fact that the use of an echinocandidin is very statistically associated with decreased mortality. The other, removal of the CVC. I have to bitch and moan to get people to yank the lines, but this is another study to show that if you leave the line in with a bug that you can't treat, the chances that the patient will do badly goes up. So take-home message from candidemia. 1, pull the line. 2, maybe not follow the beta-glucan levels. 3, start with an echinocandidin. Especially in patients whom you don't know which Candida it is, and especially in patients who have had prior azole, which increase the risk of azole non-susceptibility. Dientamoeba fragilis is a gorilla pathogen, and it causes disease occasionally in humans, diarrhea. But where does it come from? Pigs. The source of Dientamoeba fragilis, the reservoir, is pigs. And as the conclusion says, considering the size of the world's pig population, greater than 1 billion, the close contact between pigs and humans in many parts of the world, and difficulties in the proper management of pig fecal waste, the role of these animals as reservoirs for zoonotic pathogens must be carefully evaluated. That's a lot of pigs, a lot of pig poo, and a lot of potential for Dientamoeba fragilis. So, don't eat pig crap. But hey, you probably knew that, didn't you? Every time you turn around, it turns out there's more bugs out there than you think. So Mycobacterium abscessus is actually a group of 3 individual species. Mycobacterium abscessus, Mycobacterium massilensis, Massilinense, and Mycobacterium bolletii, Bolletii. And there are differences in both antibiotic susceptibilities and outcomes depending on which of these organisms you have. Mycobacterium abscessus, for example, has more inducible clarithromycin resistance. And it turns out that it's more common by about 10% to have M. massilensis than it is to have abscessus. And there's different outcomes, too, depending on which you have. So to make life more complicated, if you happen to have an M. abscessus infection, it may be one of the related cousins. The bolletii only accounted for 2. And there's difference in both outcomes and proper antibiotics. And lastly, in the world of parasites, being iron deficient was protective against severe Plasmodium falciparum and death in young children. Iron deficiency is important in protecting people from infectious diseases. Iron is a great risk factor and growth promoter of all sorts of organisms. And then finally, in the New England Journal of Medicine, they looked at the benefit of just giving everybody from Southeast Asia and Sub-Saharan Africa a dose of albendazole before they came to the United States, and found that the deworming was quite effective in removing large swaths of worms. 20% of the untreated had worms versus only 4.5%. So that's a pretty impressive decrease in the worm burden. And worms are important in keeping children from third world countries small and malnourished and subsequently developing less vigorously. And that ends it. For those of you having trouble sleeping, the Infectious Disease Society of America has released the guidelines for the treatment of rhinosinusitis in adults and children. It's free at idsociety.org, as well as all the Infectious Disease Society guidelines. They are markedly cheaper than Ambien, and I can highly recommend them for your sleepless nights. I have enormous guilt and regret that leads to late night angst, and I find the guidelines are a very inexpensive and effective antidote. So anyway, that's the end of this podcast. This has been the Persiflager's Puscast, a review of the ID literature. This is brought to you by Pusware LLC. You can find my growing multimedia empire at moremark.squarespace.com. If you like this nonsense, all I ask is to go online and rate me glowing reviews on iTunes. That's not too much to ask now, is it? This is copyright 2012 on the Creative Commons license. So, as always, thank you for this most interesting consultation, allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. But for now, I'm going to go shoot some hoops with my youngest. Bye-bye.